Hi, everyone. Welcome. Sorry, my live thing took me a second to get set up, which is weird. So let me just get a little situated here. Good afternoon, Jesse. Glad you're here. Okay, dokie. I'm so excited about today. We're talking about one of my favorite subjects, which is cardiovascular pharmacology. Hello, Shakira. Glad you're here. Getting some people on. That's awesome. Um, So I love this topic. I talk about it all the time when I'm precepting. It's one of my main topics that I talk about because I think as a ICU nurse, it's just really important to feel good about the the especially the continuous infusions that we give our patients. It's important to feel kind of good about every single medication that we give our patients, but we're in charge of titrating these medications and really watching for our patient's response to them and then alerting the providers for when things are changing and if we need to change medications. We're just so involved when it comes to these continuous cardiac infusions that I know for me, it really helped increase my confidence at the bedside once I felt like I understood how these medications were working. So felt like this would be a good idea for a webinar. Um, and yeah, I'm excited. If this is your first time here, my name is Rebecca Coulter. I am the CCRN instructor here at Archer Review. We just launched now about just over a month ago our CCRN course. It's a free course online right now on the Archer Review site. It's free for now. It won't be free forever. So definitely go in and see if you're interested. We've got a question bank with over 1,000 questions. I've got some notes on it here to prepare for your CCRN. And then we've got over 13 hours of on-demand video lecture content. And yeah, it's been really awesome to get some feedback on that and have people try it out. So definitely go to archreview.com, the CCRN page, and try out this course. I didn't talk about the CCRN at all, but in case this is your first time, the CCRN is the Critical Care Registered Nurse Certification. And we at Archer View, like I said, just launched a product to help nurses prepare for it. And we're doing these free webinars to talk about the CCRN as well. It's kind of a difficult exam. It's got a 81% pass rate, at least for 2023. We don't know what the updated pass rate is for 2024 just yet. So definitely not. It's not like everyone's passing this exam. So we wanted to come together and help out nurses get certified. Certification is such a cool thing to have. Increases your confidence at the bedside, increases job satisfaction. You usually get some sort of financial kickback from your hospital or facility for being certified. At least I hope so. That's ideal. And if you have any interest in going back to school for nurse practitioner or CRNA for sure, then CCRN is a really good thing to have and sometimes even required. So just a great certification. And it's such a good test to even just do the preparation for doing webinars like this, getting into the content. We haven't been in school for at least a little bit of time. So getting back into studying some information that relates to what you're doing every day is just kind of a good process. So glad to have everyone here. Jesse, so glad that you're taking advantage of it being free right now. That's awesome. Okay, let's go ahead and get started because I'm just so excited. This is one of my favorite topics. So, when we talk about cardiovascular pharmacology, we need to talk about the receptors and the physiology that's at play that is controlling our blood pressure just normally. Because when we start to add in drugs, it's going to work on the systems that are already built in place in our bodies. So, one of the main ways that cardiovascular pharmacology works is by acting on our adrenergic receptors. These are the receptors that are stimulated typically in our fight or flight response. And they cause a couple things to happen to increase perfusion to our key organs. So we've got two main receptors at play, our alpha and beta. So we're specifically focused on alpha 1. There is an alpha 2, but when it comes to pharmacology, cardiovascular pharmacology, it is acting on alpha 1. So when we stimulate alpha 1, we are going to get the effect of vasoconstriction. So alpha is all about our smooth muscle in our vasculature. That is where alpha is sitting. And when it's stimulated, again, we get that vasoconstriction, which we know vasoconstriction is going to lead to an increased blood pressure, which in fight or flight or in a shock state where maybe we're giving medication, we usually want to increase our blood pressure. So vasoconstriction is going to do that really, really well. So alpha is all about blood vessels. Now, beta, we've got two different types of beta as well, and we do actually kind of care about both of them for beta. We've got beta 1 and beta 2. Now, beta 1 is mostly found in the heart, and beta 2 is mostly found in the lungs. Just pull this up. I haven't pulled my Q&A up. Somebody just asked if we'll be able to watch this again at a later time. Yes. So I'm streaming to Facebook and YouTube right now. So these don't live on Archer Review's site just yet. That's hopefully coming, but you can search for CCRN webinars on YouTube, and they're living there. So yes, you should be able to watch it later on. Okay, so beta, we have beta 1 mostly found in the heart, beta 2 mostly found in the lungs. I remember this really simply. I think it's a common memory trick that we all use. We've got one heart and two lungs. So beta 1 is talking about the heart and beta 2 is talking about the lungs. When we stimulate beta 1, we are going to help that heart out. We're going to get chronotropy, which is going to increase heart rate, and we're going to get inotropy, which is going to increase contractility. Now, when we stimulate beta 2, which with our cardiovascular pharmacology, we don't super care about it. It's going to cause bronchodilation. Again, really great in fight or flight when you're running from a bear and you need to get more oxygen in. Bronchodilation is a really helpful thing. But again, cardiovascular pharmacology, not super stimulating it. But what it is, if our medications are stimulating beta 2, the result from that is vasodilation from peripheral smooth muscles in that vasculature. So that's kind of an opposite effect of the alpha, and not all drugs stimulate beta 2. Some of them stimulate alpha 1 and only beta 1, and we'll get there to what all of these drugs are stimulating. But just know that beta 2 also can affect our blood vessels and lead to vasodilation. Now, this takes us to our next blood pressure regulation physiology review, which is the CAMP system. When we have that stimulation of those beta receptors, what's actually happening is we are stimulating our vascular smooth muscle with that vasodilation, and we're stimulating our cardiac cells by increasing calcium availability, leading to that increased contractility. So CAMP is kind of when the beta cells are stimulated, or the beta receptors are stimulated, CAMP is how that action is carried out. Now, where CAMP becomes really important is when we talk about some medications that don't actually stimulate beta receptors, but affect the CAMP system. So they can cause these effects without going through the route of the beta receptors. And we'll talk about the drugs that affect that. I'll give you a hint. It's milrinone. That is a big one. But it's important to note that the CAMP system's involved anytime we're stimulating beta receptors. So our other drugs, epinephrine, dobutamine, that stimulate beta, they're also using CAMP. But milrinone kind of uses a backdoor way to get there. And we'll talk about it here in just a little bit. So just with remembering these key receptors, alpha and beta, I've got a little bit of a memory trick, and I don't know if it's helpful at all, but I always say it just in case it is. If you are struggling to remember that alpha is talking about blood vessels and vasoconstricting those blood vessels, and beta, specifically beta 1, is talking about the heart, the way I kind of think about it, the alpha symbol looks to me like a fish, and I just think of a fish swimming in a river, and that river would be the blood vessel. And it's either a really wide river or it's a really, really tight river that fish is swimming in. So when I see that fish symbol, I'm thinking blood vessel. And with beta, I think beta 1 and beta 2 with the heart and lungs. It kind of looks like a heart to me. If you were to flip it upside down, that's a little bit of a stretch, but just little memory tricks. All of our drugs are going to use a lot of alpha and beta, and we've got some other receptors at play that we'll get to when we talk about specific drugs, but these are the big ones. Really feel good that alpha is increasing our vasoconstriction to increase blood pressure, and beta 1 is going to give us that inotropy effect. Okay, and it's going to use the camp system to do that. So now we're going to play a little bit of a game. Um, I've got a blank chart here, and these are all that I could think of at least are major cardiovascular medications that I see in use all the time. These are our vasopressors. These are our, I've heard the term inopressors that do multiple different things, inotropes, more pure inotropes. And these are these medications that we're giving as continuous infusions. Some of them are at set doses. A lot of them we're titrating. And these are the medications that if I were you, I would say I feel really, really good about how many even is this? 7? About these 7 medications and how they work. So I want to make this a little bit more interactive. Now that we've gone through the physiology, I'm going to go take this one medication at a time. And if you can tell me from your experience which receptors each of these medications are working on. So we're going to start with phenylephrine. We're going to take it one at a time. Can anyone tell me the receptor that phenylephrine acts on? Or receptors if it acts on both or 2? Okay, I've got one answer. That was so fast. Okay, I'll take it. I only got one answer. Y'all can also just answer to yourselves. There's no pressure to answer to me. But it helps me know where we're at, what we're thinking. So phenylephrine is going to act all on alpha. And I have 4 of them listed here because when we get to some of these other drugs, some of them act on multiple of them, but they act at different strengths on different receptors. So it's kind of a way that I can say which one is it acting more on than another. So phenylephrine is pure alpha. Excuse me, just absolutely pure alpha. Um, what does that mean for our patient? What is the main action that we're getting from pure alpha stimulation? What can we expect to see? You're good, Shakira. You're doing great. Perfect. Absolutely. Jesse, Yenicel. Awesome. Vasoconstriction, right? We just talked about how we have alpha receptors, little fish in the rivers, vasoconstriction. Again, it might totally not be helpful. So yes, we are increasing huge, huge, huge vasoconstriction. So we're clamping on these blood vessels and we're getting blood flow to our organs this way. Now, what types of conditions do we think phenylephrine would be really good in? When would we want pure alpha, just vasoconstriction, nothing else? We don't really see it a ton. It's not like the first line pressor. So what type of conditions can we think of that we would want pure alpha? Perfect. Somebody said sepsis. That's maybe anaphylactic shock phase. Yes, because we know that these distributive shocks they're characterized by huge vasodilation. So yes, we can use them in sepsis, septic shock. We can use them in really any shock phase other than probably cardiogenic. But we're not going to use it as a first line because it is such pure alpha. It's going to increase our afterload so much that it might overwhelm the heart. And that's why we're going to start with something like norepinephrine, but we might need to add phenylephrine on later. Another shock phase that it's really good for is neurogenic shock, where our whole problem is that we don't have any sympathetic nervous system to stimulate our alpha receptors. So giving phenylephrine when we are in huge vasodilation and theoretically our heart can handle it, is a really good idea. Now, a place we want to avoid phenylephrine is if we have any sort of bradycardia with our patients. We can cause some reflex bradycardia with phenylephrine because the baroreceptors in our blood vessels are sensing that we are in a massively vasoconstricted state. And they're going to say, oh my word, we've got lots of blood pressure or a lot of vasoconstriction. One of the compensation phases for that is to decrease cardiac output and lower the heart rate. So if we have any amount of bradycardia at all, we're going to steer clear from phenylephrine. Great job. Okay, let's talk about norepinephrine. What receptors is norepinephrine acting on, do we think? And you don't need to put up the 4. You can just say which ones. Perfect. Awesome job, Yenisel. Great job, Shakira. Anyone else? Yes, alpha and beta. So let's take a look. We've got alpha and beta receptors being stimulated by norepinephrine, but they're not perfectly balanced. We're definitely, great job, Jesse. That's exactly right. It's stimulating alpha, but it's got just a little bit of beta in there, which is kind of nice because what happens when we have alpha stimulation and we've got huge vasoconstriction, we are increasing the afterload for the heart significantly. And sometimes the heart can handle it. We've got really good functioning hearts out there. Or the heart might need just a little bit of help. We can help it squeeze, give it a little bit of contractility, a little bit of chronotropy to help overcome some of that afterload that we're creating with all of this alpha. So that's why norepinephrine is considered our first line pressor because it's got a little bit of both. We can assume it's going to help a lot of things. Um, and so it's a great pressor. It's not necessarily the perfect pressor for every patient. Sometimes I don't even like that we have first line and second line titles for pressors. I think we should look at every single patient and be like, what do they actually need? And then choose what pressor they get. But I will say that for a lot of shock states like sepsis, even hypovolemic shock, if you're at the point that you need to add a pressor, norepinephrine is a really good choice. So I can't be too mad. I'm going to skip asking what our main action is because I've already seen a lot of people say it. We're going to get that vasoconstriction from the alpha. We know that. And then we've got a little bit of inotropy and chronotropy. And this is why sometimes when we're on norepinephrine, we can see an elevated heart rate because of that little bit of beta. Okay, tell me about epinephrine. Where is epinephrine acting? What receptors? Good job, Unicell. Hope I'm saying that right. I'm sorry if I'm not. Good job, Jesse. Perfect. Betas. Now, again, it's a little bit nuanced. We're seeing lots of beta and just a little bit of alpha, but it's kind of flipped from norepinephrine. We've got more beta than we do alpha, but we do get just a little bit of alpha. So what actions can we expect from epinephrine if we've got all this beta? Good job. What is beta 1 stimulation going to do? Specifically beta 1, which Jesse pointed out. It's going to increase our inotropy and chronotropy, right? So we're going to increase our heart rate. Exactly. So we're going to increase the heart's ability to squeeze, increase the heart rate. These are all things. If we can increase the heart's ability to squeeze, we're theoretically going to increase stroke volume, increase heart rate. Stroke volume times heart rate is cardiac output. We can help our cardiac output with epinephrine. Now, something I want to say is epinephrine's a little bit interesting in the fact, and we'll get to another medication that acts in a similar way, we can see a change in how this drug is metabolized given what dose it's on. So in really, really low doses, like 0.02 to 0.05 mics per kg per minute, which is really, really low, we are seeing pretty much pure beta. There's not really any alpha at all when we're in that super, super low dose up to 0.05. When we get to 0.05 to around 0.1 mics per kg per minute, that's when we're pretty much equal. We've got both alpha and beta on board. Now, when we're over 0.1 and over 0.2, it's actually a lot of alpha. And I did not know this for a really long time. And I worked in a cardiovascular surgical ICU for like the first many years of my career. And this really didn't come up too much. So I'm curious to hear, is that coming up for y'all in practice? It's come up a little bit for me more recently that we're noticing, at a certain dose, if we're on 0.8 mics per kg of epinephrine, we're really just on a second norepinephrine at that point. It's really a lot of alpha. But again, I just didn't see that a ton in practice for a really long time until more recently. So something to keep in mind. It might not totally change practice right now. If we're seeing a patient who has low cardiac output and we're wondering what pressor is good for them, we're probably still going to put them on epi if we think they need a little bit of vasoconstriction as well. But it is something to keep in mind when you're getting really, really high in dose. It might not be working as much for the beta as we think. Okay. Oh, I just gave you the answers. I knew I was going to do that too when I was making these slides. I was like, I have to make sure I don't click when I'm not supposed to click. Vasopressin is a weird one. You can tell me, just for the sake of it, even if you saw it, what receptors is vasopressin acting on? And the other term for it really is antidiuretic hormone, which kind of gives us a hint. So vasopressin is working on V1 and V2 aldosterone. Yes, it's kind of part of that RAS system, that renin-angiotensin aldosterone system. Great, great job. So yes, it's working on V1 and V2. Now, V1 is living in our vascular smooth muscles. So when we stimulate V1, we're going to get some vasoconstriction. So vasopressin it's a pressor, which means it's acting on our blood vessels and constricting them. So we're getting that vasoconstriction from V1. V2 is sitting in our renal collecting ducts. And this is where what some of y'all said in the chat, we are going to see increased water reabsorption in the kidneys, increased water retention. So we're tackling blood pressure in two different ways now. We're seeing vasoconstriction to increase blood pressure and water retention. We know that if we can increase the amount of volume in the vasculature space, the blood vessels, then we will increase blood pressure. Volume equals pressure most times. Okay, before I almost clicked it again. Dobutamine. What is dobutamine acting on? Y'all are doing a great job. I'm going to give you a hint. Dobutamine is a pure inotrope. So what is it going to act on that would lead to our inotropic effects? Beta. Perfect. Now, the interesting thing about dobutamine that varies itself from epinephrine up here is it's working on beta 1 and a little bit on beta 2. So when we think about what it's doing with beta 2, think less about the bronchodilation and think more about that other thing that it did. So with beta 1, we know we're getting inotropy and chronotropy. We're increasing the squeeze and increasing the heart rate. Perfect. We're getting that with dobutamine. We're also getting a little bit of beta 2, which is going to cause that vasodilation. And why would this be helpful as an inotrope? What is vasodilation going to do for the heart? There's a couple ways you can answer that. Beta 1 will increase our heart rate. Beta 2, vasodilation, is going to help the heart out in a different way. Yes, open the blood vessel, reduce our afterload. So it's going to help the heart out even more. It's going to say, now not only am I helping you squeeze, but I'm also going to open up that aorta that you're squeezing into, and I'm going to make that job easier. And you're not going to have a ton of high resistance after to push into. So it's going to cause those two things, inotropy and vasodilation. Now, sometimes our blood pressure can't handle this vasodilation, and that's where we might see our patients be on multiple different infusions. We might need the dobutamine help to have that pure inotropic effect, get some contractility, but we can't really, the blood pressure is not handling the vasodilation very well. And that's when we maybe need to add in some alpha. So we'll have somebody on dobutamine and norepinephrine. This is very common when we start to see mixed shock states where we can have cardiogenic shock mixed with a septic shock, which is a vasodilation distributive shock. That means we really need to support this heart with some contractility, some beta, but we can't handle the effects of that vasodilation. So let's throw some norepinephrine on to counteract that part, but still give that patient more beta. Okay, dopamine is a really interesting one. What is dopamine acting on? Good job, Alvin. Yes. Dobutamine, definitely to increase cardiac output. When we're on dobutamine and any really of these last three medications, I love to have a Swan catheter in place, a pulmonary artery catheter, so I can test my cardiac output and titrate medications based on cardiac output and not blood pressure. That's definitely the ideal. Not that you can't do it with just blood pressure, but it's definitely ideal to see that cardiac output. What is dopamine acting on? This is a little bit of a trick question. So I'll go ahead and answer it. So I've got these dots, meaning at certain doses, things are changing. And it's really concrete for dopamine, a little bit less concrete for epinephrine, at least from what I'm seeing in practice. So in early doses, I think around like 0 to 5, it is stimulating our dopamine receptor. And this is really good for I think I said that wrong. Did I say 1 to 5? It's 1 to 3. 1 to 3 mics per kg per minute. That D1 receptor is being hit. And it's really good for renal vasodilation. So sometimes we'll say we're renally dosing this dopamine. So we're putting them on a low dose to help prevent an AKI. So we can cause this vasodilation, give a little bit more blood flow to the kidneys. Now, studies are kind of varied on if they actually think this is helpful in AKI, but it's definitely something that I'm still seeing, so we should talk about it. Now, when we get to our next set of doses for dopamine and we get to the 3 to 10 range, this is when we're acting on beta 1. So this is where dopamine is that pure inotrope that I was talking about before, where between those doses of 3 to 10, we are getting, we're stimulating the beta receptors, starting that CAMP system, inotropy, contractility, and chronotropy, all of that, increase in cardiac output. Now, after 10, when we get that 10 to usually 20 is the max for dopamine, in that range, it turns to pure alpha. So this drug changes a lot depending on how much we're giving to the patient. So it's something super important to consider when you're titrating. And hopefully you're talking with the provider, or the provider's talking with you about what is the goal of this dopamine? Do we want it for renal perfusion? Do we want it for increased beta? That is going to determine what dose you put this patient at. It's not, oh, you're on a low dose and then you just titrate up as needed and titrate down as you can. It's a little bit more nuanced with dopamine. Okay. Next is milrinone, which is one of my favorites. What is milrinone acting on? And I'll give you a hint. It is not on the screen at all. It's not acting on alpha and beta, and it's not acting on dopamine receptors or vasopressin receptors. Yay! CAMP, yes. It affects the CAMP system. It's technically acting on something else that affects the CAMP system, but that's still right. So it is acting on, let me just include it here, PDE3, which is phosphodiesterase, phosphodiesterase 3, and it's inhibiting that. Now, what phosphodiesterase does is it inhibits CAMP. So when we want more CAMP, we know that CAMP is going to increase our contractility and increase some vasodilation of our blood vessels. When we want more of that, we can inhibit PDE3 to get more CAMP. So that's what milrinone's doing. So it's kind of taking, again, that backdoor way to affect the CAMP system that doesn't involve beta receptors. Now, what's really interesting about milrinone is it is very effective for right-sided heart failure, because instead of just having that vasodilation occur for the aorta or more systemic blood vessels, it can target pulmonary vessels a little bit better. So this is really good when we have a patient who has pulmonary hypertension, their afterload for their right side of the heart is really increased, and we want to settle that down. We can give milrinone, vasodilate the pulmonary artery and the pulmonary artery arterial vasculature, lower the resistance in the pulmonary system, and help out the right side of the heart. So that's just kind of a fun fact. If you've got somebody with total heart failure, it's not just left-sided heart failure, which is what we see most often, but their right side isn't looking great either. Advocate for milrinone. Milrinone's a really great option. Now, it's going to cause that vasodilation. So sometimes with our patients in those mixed shock states that already have some sort of vasodilation going on, they might not be able to tolerate milrinone. But if they can, it will reduce afterload. It's just a really good heart medication for that reason. Okay, awesome job. See, now we've got a filled out table and you know everything about all of these medications. Great job, everyone. I had some practice questions here, but that took me longer to go through than I anticipated. So we're just going to do one of them. And I kind of want to see if I want to pick which one I want. Um, let's do this one because I kind of like that it includes a couple different things going on. So let's go through this practice question together. A 74-year-old patient in the ICU with cardiogenic shock following an inferior STEMI. The patient is currently receiving dobutamine at 5 micrograms per kilogram per minute. Repeat hemodynamics after 2 hours are showing the following. What is our appropriate next step? Great job, Shakira. Anybody else want to give it a shot? Okay, Shakira got it right. It is B. We're going to add norepinephrine. Oh, good job, Brooke. Brooke, I think. Yeah. Um, yes, we're going to add norepinephrine for this patient. So they've been on dobutamine now for 2 hours, and we've got a MAP of 59. So we know that dobutamine can cause some vasodilation to help reduce the afterload of the heart, which is great. But a lot of patients can't handle it. Looks like he's in cardiogenic shock. He might have something else going on too. So we're going to add norepinephrine, get this patient some squeeze. Um, if we just were to increase, our cardiac output and index are not ideal yet. So you might look at that and be like, well, is my hypotension related to my really reduced cardiac output still? Or is it more of a vasodilation problem? So some could advocate for increasing that dobutamine infusion, but after 2 hours, we should try norepinephrine and get that started. And then um, try norepinephrine, get that started, and then see where we can go. Dopamine wouldn't help. Dopamine could help. It just depends on what they're thinking with the patient. What we would maybe need to know is how much did the dobutamine help our cardiac output and cardiac index? Where did we start? If we were seeing good increase in that cardiac output and cardiac index, since these are low, but they're not, totally in the trash. Maybe we started lower. If we know that dobutamine was working for that beta stimulation, then we'd want to stay on dobutamine and then get our blood pressure a little bit higher. And we could maybe even increase dobutamine after we start norepinephrine. So it's something that we could play around with. But the only other thing that I would consider too with dopamine is we might get more dopamine has a higher risk for causing increased heart rate than dobutamine, which is kind of just a nuanced thing. And we already have a borderline heart rate. So that would maybe be a reason they wouldn't want to go dopamine, but it is nuanced. Either way, with this question, when we're looking at this set of vitals, the answer will be add norepinephrine, but it's a good thing to think about. And then that's where test questions sometimes don't paint the full picture for what you would do at the bedside. Either way, we've got to fix our MAP problem here. And then they might say, okay, we aren't getting enough from dobutamine. Maybe we switch to dopamine. Great question, Jesse. Perfect. Okay. I want to do one more. I'm technically out of time, but I'm going to do one more. Definitely feel free to drop off if you need to. These are just kind of fun. I feel like that one's kind of similar to what I already did. Okay, I like this one. This kind of like closes out the story. So a 73-year-old male with a history of ischemic cardiomyopathy with an EF of 25% was admitted to the ICU in cardiogenic shock after an acute anterior MI. Lots of information. He has been on dobutamine at 5 mics per kg per minute and on norepinephrine at 0.05 for 72 hours. That's kind of a long time, 3 days. These are our hemodynamics. Given that the team is considering weaning off of inotropes, what's the most appropriate action at this point? Great job, Alvin. Great job, Shakira. We'll give it just a couple more minutes, a couple more seconds. Lots of different answers. That's good. I kind of love when that happens because then we can talk about it. So what I'm seeing most are B and C, which are both kind of telling us to do the opposite things, right? So B is saying taper norepinephrine first, then begin to slowly wean off of our dobutamine, whereas C is saying start with our dobutamine, keep norepinephrine on, and continue to monitor from there. So the answer here is C. We are going to come off of that dobutamine first. We have a good indication that we've gotten a great effect from our dobutamine. Our cardiac output and cardiac index look good. We know that dobutamine can cause a little bit of that vasodilation. So if we were to come off of what was it, norepinephrine first, we might unmask some of those vasodilation effects. The easiest way and the best way to do this is wean off that dobutamine, see what happens with our cardiac output and cardiac index. And then we should theoretically be able to come off of norepinephrine, especially at such a low dose here, pretty quickly. We'll watch all of our numbers, make sure cardiac output and cardiac index doesn't drop. But if we wean off our dobutamine first, it just protects from maybe some of that vasodilation. Why we needed the norepinephrine was that dobutamine, and then we can come right off of the norepinephrine. If we come off of norepinephrine first, then we might have a good amount of vasodilation present because dobutamine would be on by itself. Does that make sense? And we would not discontinue both at the same time. We really don't ever do that. So good job for nobody picking that one. We would have no reason to switch to milrinone. Milrinone has a longer half-life. If we found that dobutamine worked, we would not switch to milrinone. We're just prolonging the process, basically. Okay, that's kind of a difficult question. So great job, everyone. As a general rule, I would say, at least in practice, that's what I see. When we are in this situation, we'll come off of the more invasive agent first, which I consider inotropes to be, a little bit more support. And we'll see how that goes. Leave norepinephrine on. We can wean it off as soon as we know that the dobutamine wean went okay. Okay, great job, everyone. We've got a webinar next week, and this one's really exciting because it's going to be, I don't even think I put it on this slide. It's going to be a CE webinar, so you can get a contact hour for attending if you attend via Zoom. So definitely hit this link. It's also, if you go to archerreview.com and go to the CCRN page, it's pretty much right there near the top, where you can sign up for any of these webinars. But definitely sign up for this one, again, through the site, through the link. Then you get a Zoom link to your email. And if you join on Zoom, that's when we are able to send you a certificate for being present for this hour long. This one will be an hour webinar. If you join, I'll still stream it to Facebook and YouTube just for fun, but unfortunately we can't verify that you were present for long enough. If you want the certificate, you have to be present on Zoom for 80% of the webinar. So click this link, go check it out. We'd love to see you. ECG interpretation crash course. I'm just going to go through all the arrhythmias, go through myocardial infarction, changes on the ECG, and our treatments. pacemaker, cardioversion, defibrillation, all that fun stuff. I just think you can never talk too much about ECGs. We always need it. Um, okay. Yay, Shakira, you'll be there. Awesome. Was this helpful for everyone? Did this clear up any concepts or was it not helpful? Very, okay, good. I always ask because I never know, so I just like to make sure. Okay, that is it, everyone. This is that link. I'll leave it up here for just a second, and we will see you next week, 12 p.m. Central. Thanks, Regina. You're new to CVICU, Alicia. That's awesome. CVICU is where I started. I love CVICU, but the learning curve is extremely steep. I totally get that. So I am very excited for you. CVICU is such a fun place to work. Okay, everyone, we will see you next week for that CE webinar.